Okay, I am delighted to introduce our next speaker, Dr. Paul Ladinson, who is the John Eager Howard Professor of Endocrinology and Metabolism and Professor of Medicine, Pathology, Oncology, and Radiological Sciences at Johns Hopkins University School of Medicine, where he's also a distinguished professor. He was educated at Dartmouth, Oxford, and Harvard, where he moved on to training in internal medicine and endocrinology at Massachusetts General Hospital. He's the founding director of the Johns Hopkins Thyroid Tumor Center in 1988, has served as president of the American Thyroid Association, editor-in-chief of the JCEM, and chair of the American Board of Internal Medicine Committee. And his principal research interests are innovations in thyroid cancer care, cardiovascular effects of thyroid hormone, and he has been the author of more than 280 publications. We are very honored to have you, sir, and very eager to listen to this. Thank you.
Thank you. Well, thank you, Dr. Makin. Thank you to you and Dr. Sipperstein for inviting me this morning. It's a pleasure to be here in person. And I think for some of you, it's your first time in person at your own session in some months. I also want to thank Dr. Ludholm for that nice introduction to my talk and the presentation of the case that I had at Johns Hopkins that inspired me to investigate this evolving area. Well, our lives have really been turned upside down, haven't they, over the past 2.5 years or so, with an event like none other those of us who are in practice now have ever seen. And the reverberations of this pandemic have gone, as we all recognize, well beyond healthcare into economics and politics. And it has led to questioning of many ideas in all of those realms. I want to emphasize looking at this dashboard that Johns Hopkins has developed and that became prominent early in the pandemic, just to remind you of the magnitude of what's happened and how it has pervaded the health and healthcare of everyone whom we see, with more than 500 million cases as of Saturday, when I captured this image in the United States. And importantly, with almost 11 or almost 12 billion total vaccine doses administered in the United States. And I want to emphasize that issue of vaccine administration incidence here by highlighting that chart on this website, and remind you that the case you've just heard about occurred here in the spring of 2021, at a time when millions of Americans were being vaccinated every week, indeed for a period of time every day, with the COVID-19 vaccine. And so obviously incidental associations are important for us to consider as we talk about causal relationships. So what I'd like to do today is cover these topics: the pathophysiology of thyroid involvement with COVID, the thyroid function test changes that we're not surprised occur with this severe non-thyroidal illness, as it does with so many others. The intriguing question that's been asked this morning about whether subacute thyroiditis can be caused by COVID or vaccination against COVID, and whether Graves' disease affecting the thyroid or the eyes or other autoimmune thyroid disorders are more likely to occur with COVID exposure. Talk about those same issues with regard to vaccination, try and provide some amateur epidemiological context, and then ask the important question that was asked of Dr. Al-Hajj a moment ago, that is whether our patients with thyroid disease need be wary about COVID infection, particularly, or COVID vaccination. So as you've all come to learn, COVID gets into cells by attaching to the angiotensin converting enzyme 2. It is the receptor for SARS-CoV-2 cell entry. And early on, Nicholas Rotundi in Switzerland investigated whether there was in thyrocytes expression of the ACE2 enzyme and COVID receptor using RT-PCR. And as you can see, Nick found that ACE2 was abundantly expressed in 2 sets of thyroid tissues that he investigated, 15 surgical thyroid tissues, and also in primary cultures of thyroid cells. And here you see that mRNA expression level in comparison to other constitutively expressed mRNA species. Along with the ACE2 molecule, there is a second protein, the type 2 transmembrane serine protease, that is a cofactor essential for CoV2 entry into human cells. And it too, in other work from Italy, has been shown to be abundantly expressed in thyrocytes. Consequently, there's every reason to believe that the machinery is there in thyroid cells to promote SARS-CoV-2 entry and then its subsequent amplification in human thyroid cells. And indeed, in this study, using immunohistochemistry, Poma and colleagues showed that SARS-CoV-2 nucleocapsid proteins were detected in postmortem thyroid tissue from 9 of 25 patients who had died as a result of COVID infection. So I think we can really be quite sure that thyroid cells are indeed vulnerable to COVID-2 infection. Now, not surprisingly, a familiar pattern of thyroid function changes have been described in patients, particularly critically ill patients admitted to the hospital with SARS-CoV-2 infection. I want to just show you a few of the larger series describing these changes. This is a study from Imperial College London looking at a cohort of adults who were admitted with suspected COVID, 73% of whom in fact proved to test positive for COVID after admission. These investigators excluded individuals with pre-existing thyroid disease or those who didn't have the studied thyroid function test values. The vast majority of these patients remained euthyroid, 87% throughout their illness. In this series, none of the 456 patients had overt thyrotoxicosis. It's of note that the COVID-19 patients, though, had a lower admission TSH and free T4 compared to a control group of patients admitted without COVID. And among these COVID patients in the National Health Service, a number had previous thyroid function tests obtained during the course of their routine care. And in comparison with those TSH and free T4 values, their admission thyroid function tests, both TSH and free T4, were lower. So lower TSH and free T4 compared to controls and compared to their own healthy status. And in 55 of these patients, there were thyroid function tests measured in addition after outpatient recovery from their COVID infection. And here you see the, let's see if I can move this around a little bit.
So that window doesn't show for anybody else.
Okay. So you can see here the reduction in TSH modest, you can appreciate as well. And it's returned to normal in these individuals admitted with COVID infection. These investigators also looked at the relationship between the severity of COVID infection and thyroid function test changes. And you can see that the serum TSH of patients who were admitted to their intensive treatment unit in London were modestly but significantly lower than the TSH values of individuals who were managed outside of intensive care. Now, all of this for endocrinologists, of course, rings a bell, doesn't it? It's what you would see if you went to your own cardiac ICU this morning, or to the critically ill patients throughout your hospital. In this study from China, early in the course of the COVID pandemic, a retrospective review of 50 patients who'd been admitted with COVID and had their thyroid function tests monitored then and after recovery, in comparison with two sets of control patients, individuals who had a routine physical examination in presumably good health, and also, interestingly, a group of patients admitted to the hospital with pneumonia that was non-COVID-19 related. And you can see that in this study, more than half of the admitted COVID-19 patients had a subnormal TSH, and that the TSH and T3 values in this study were lower in those patients than the two control groups, the healthy individuals and the non-COVID pneumonia inpatients. These investigators in China also found that the more severe course of COVID, patients with the more severe course based on their symptoms, laboratory parameters, and a rating scale of chest CTs, had lower TSH and total T3 values than individuals with milder bouts of COVID. And they found that after recovery, there were no significant differences remaining in TSH, T3, total and free between the COVID patients and controls, suggesting again that these changes were what we've come to conventionally expect in patients who are ill with the whole spectrum of non-thyroidal illnesses. In this study from Brazil, a prospective cohort study to again look at thyroid function parameters and how it related to the severity of COVID infection, and in this study, mortality, There were 245 patients whom they stratified based on standard severity of critically ill patient scales into critically ill and non-critically ill patients, 24% of whom ended up admitted to the ICU and 17% of whom ultimately died. In the critically ill patients, these Brazilian investigators found that the free T4 level, the free T3 levels were lower than non-critically ill COVID-infected patients. And they also observed that there was, in fact, a correlation between mortality and T3 levels, and provided actually cutoff T3 levels that predicted impressively higher risks of death related to COVID infection. In this study, interestingly, TSH and free T4 were not significantly associated with disease severity. I think we all know that T3 represents the most sensitive parameter reflecting non-thyroidal illnesses because of the prompt inhibition of T4 to T3 conversion with non-thyroidal illnesses. But with this study and the others, I think it's important to say that there has, to my knowledge in the literature, yet been no demonstration that in this study, for example, free T3 values provided prognostic insight beyond those that are generated by conventional critical care scales like Apache and other predictors of mortality in ICU patients. A final study of this sort, again from China, a retrospective study in 235 patients where mortality, ICU requirements, assisted ventilation requirements were compared in patients who had different flavors of non-thyroidal illness. Those with severe non-thyroidal illness where not only the free T3 and free T4 were low, but also the TSH low, a phenomenon that we believe is related to circulating cytokine effects on the hypothalamus and pituitary. Individuals with normal TSH but low thyroid hormone concentrations, which are called mild to moderate non-thyroidal illness, and then a pattern that's not infrequently seen during recovery from non-thyroidal illness of subclinical hypothyroidism, where the hypothalamus and pituitary are waking up and the TSH is elevated with normal free T4 and T3 values. And as you can see, 5% of the severe non-thyroidal illness syndrome is defined in this study, 10% in the mild to moderate, and 7% had a subclinical hypothyroidism picture of non-thyroidal illness. So all three patterns seen. And you can see that when these investigators looked at their homegrown severity score based on the need for ICU hospitalization, ventilation, and chest CT appearance, that these three classes of non-thyroidal illness were associated with the severity of patients' COVID-19 infection syndrome. So in this study, as in the others, as I mentioned, no demonstration, though, that thyroid function test data has incremental prognostic accuracy versus conventional critical care scales. And I don't think we as endocrinologists have grounds for recommending to our ICU colleagues that they check thyroid function tests, and it will just keep us busier in the evening on our inpatient consultation rounds but I think not assist in the care of COVID-19 infected patients. Now, this morning we've heard about a patient with subacute thyroiditis that followed vaccination, and I've shown you a pretty convincing story of COVID-19 entry into thyrocytes and expression in thyrocytes. What about subacute thyroiditis? And I thought I would just spend a moment reminding you of de Quervain thyroiditis. This is Fritz de Quervain himself, who was among those to first describe this syndrome of painful thyroiditis with other synonyms, and review our incomplete understanding of its pathogenesis in general. We do, I think, understand the characteristic triphasic changes in thyroid function that occur with subacute thyroiditis. Initially, the thyrotoxic phase caused by unregulated release of stored T4 and T3, followed in the majority of cases by a hypothyroid phase with impairment of thyroid hormonogenesis due to inflammation, we believe, and impairment of the molecular and biochemical machinery needed for thyroid hormone production, and also by the suppression of TSH that lingers after the thyrotoxic phase. And then in the majority of cases, in most series, 75 to 80% of patients, a return to normal thyroid function. Now, I think the principal line of thought has been that subacute thyroiditis may be a viral infection. Many patients have prodromal symptoms that are characteristic of a viral syndrome. In temperate zones, it's more common in the summer, as many viral diseases can be. It has been associated, subacute thyroiditis, with epidemics of viral infection, especially with mumps. And in a handful of cases, mumps virus has in fact been isolated from affected thyroid tissue. But it's also been associated with influenza, measles, the common cold, mono, and a variety of other viral infection. In one oft-cited case, electron microscopy demonstrated viral particles in a surgical specimen from a patient with subacute thyroiditis. And the concept of this being a viral infection has also been supported by antibody titers in stored sera from before illness, during, and after, showing increased antibody titers to Coxsackie mumps, echoviruses, and others. There does appear to be, in addition, a genetic predisposition to subacute thyroiditis with certain HLA haplotypes. It is a haplotype that's highly prevalent in Chinese and also in Caucasian subacute thyroiditis patients. With regard to autoimmunity and its potential role in subacute thyroiditis, I think there's no clear association of thyroid autoantibodies with this syndrome. And autoantibodies are, as you know, seen generally in a low titer in about 20 to 25% of these patients. There have been previous case reports of subacute thyroiditis related to vaccination for other viral illnesses, hepatitis B, the flu, H1N1, and also cases of subacute thyroiditis that have been reported after first generation immunomodulatory drugs. Michelle's done a great job, I think, of presenting a critical inspection of the Asia syndrome, which I think she pointed out, and I certainly agree, needs to be understood with a grain of salt. So what about subacute thyroiditis? Well, the first case reported in 2020, and it's fun to look into a subject where the entire literature is over the past about 36 months, where, of course, there was just nothing about COVID infection and the thyroid previously. This is the first report in an 18-year-old woman who developed subacute thyroiditis 15 days after being shown to have the SARS-CoV-2 infection. And you can see here that premonitory phase, the characteristic thyroid function test with a T4 predominant case of thyrotoxicosis, TSH suppression. Interestingly, in this case, also characteristic modeled hypoechogenic regions of the thyroid gland that have been previously described as typical of subacute thyroiditis. And there have subsequently been case reports and small series from around the world here, from Italy, from India, and from the Arab world, describing subacute thyroiditis patients who had associated temporally associated episodes of COVID-19 infection. In terms of small series, this is one in which there were 21 cases of sort of typical patients with subacute thyroiditis, where the mean interval between the start of COVID-19 infection and subacute thyroiditis was a bit more than 3 weeks. 5 of these 21 patients had prolonged COVID, whereas in 16, the COVID had resolved before the subacute thyroiditis. The majority had fever and neck pain, which is interestingly almost invariably seen in wild type subacute thyroiditis. And there are other suggestions that if there is a specific form of subacute thyroiditis with COVID-19, that it may be more likely to be uncharacteristically painless. Thyrotoxic symptoms were present in almost all patients, and laboratory documentation of thyrotoxicosis in everyone, as well as conventional markers of systemic inflammation. All of these 21 patients had ultrasound findings suggesting subacute thyroiditis. The treatments that were used were those we typically employ, and all of the patient's symptoms recovered or resolved, but a quarter of them became hypothyroid long-term. Not much different than what we expect with conventional subacute thyroiditis. This is a case that was presented last autumn at the European, or really 3 studies, and these are not all the studies at this European Congress last fall that were reported, but I just picked these 3. One of 51 subacute thyroiditis patients, 9 of which were after COVID infection, 18 after COVID vaccination in these European patients. Again, the prevalence of documented thyrotoxicosis was no different among the COVID-19 infected patients and those without a history of COVID exposure or infection. Another report from Belarus of 26 cases, 18 of which followed COVID-19 infection. And in this case, which is an outlier, unlike the rest of the literature, a much higher prevalence of permanent hypothyroidism, described here as being 2 out of 3 patients having permanent hypothyroidism, whereas it was the more conventional 25% of sustained hypothyroidism in the non-COVID cases. And in 7 of these COVID-associated SAT cases, all of them returned to normal thyroid function in this study from Kosovo. I think kind of an interesting aspect of this in terms of the medical literature is also the way that people from around the world have been able to participate with their clinical experience, and that's laudable, but also perhaps reports from institutions where traditions and standards of rigor are perhaps not as high as they are at the Cleveland Clinic. Now, Graves' disease, what about its incidence as a new disorder and its recurrence after COVID infection? Well, there's also been a literature of case reports related to Graves' disease, with the theme, like the first one listed here, of relapses of Graves' disease after periods of remission in patients following COVID-19 infection. Also, you see here cases with the new onset of hyperthyroidism, cases where there has been both hyperthyroidism and ophthalmopathy. At dinner last night, we talked about a case seen here with severe ophthalmopathy occurring in temporal relationship to COVID infection. But the main theme here in the case report literature is of relapse of previously remittent Graves' disease after COVID infection. Now, our case relates to the issue of COVID-19 infection, and it is, I think, a very important issue because of the innate reluctance of many people to COVID vaccination, and the need to really be sure about our advice with regard to thyroid disease representing a risk of vaccination or not. And I'll make some comments about vaccination's relationship to subacute thyroiditis, to Graves' disease and Graves' orbitopathy. You've heard about my patient who in April of last year had these typical symptoms of thyrotoxicosis, had typical thyroid pain and tenderness, and typical systemic inflammation signs, that whole triad that characterizes typical subacute thyroiditis. Her notable distinction here was that it all occurred after her dose of the J&J vaccine. And she came to me wondering about this relationship. You saw too how her course in terms of thyrotoxicosis was typical. Interestingly foreshadowed, though, by this suppressed TSH 6 months earlier, which of course remains unexplained. We know that she did not have TSH receptor antibodies, suggesting there was at least not diagnosable pre-existing subclinical hyperthyroidism due to Graves' disease. And then by later in the spring, all of this before she came to Johns Hopkins, the inappropriate initiation of methimazole, which was fortunately promptly recognized based on the very low thyroidal radioiodine uptake, and then her ultimate recovery. Well, this case was really not worth reporting because there had, when I looked into it, been a number of reports of subacute thyroiditis following SARS-CoV-2 vaccine. Here, among the first from Turkey, 3 typical cases of subacute thyroiditis in younger women starting days after the dose, in this case of the Chinese developed COVID-19 vaccine, in patients with no previous history of thyroid disease or of COVID infection. The Asia syndrome was invoked by these authors as a potential explanation for their illness, and they, like the case after infection, showed the characteristic echocardiographic features of subacute thyroiditis in their SAT syndrome related not to COVID infection, but to immunization. Here's the final chapter in my own patient's ultimate recovery. She was remarkably patient in awaiting the return of normal thyroid function, and ultimately that occurred. Now, vaccination has also been associated with Graves' disease relapse in one interesting case, also of the onset of type 1 diabetes after vaccination, of thyroid eye disease occurring after vaccination. But in both a randomized controlled trial and in a prospective cohort study from China enrolling recipients of an inactivated SARS-CoV-2 vaccine developed again in China, and then monitoring of thyroid function tests, thyroid autoantibody levels before the first dose and 28 days after the second dose, you can see that 6% of individuals developed thyroid dysfunction biochemically during this period of observation around the time of their infection. Among the 545 recipients who had baseline negative antithyroid antibodies, none developed abnormal antibodies after vaccination. Among the 93 recipients who initially had abnormal thyroid function tests before the vaccine, 75% returned to normal function after the vaccination. And the levels remained positive after vaccination in 96% of TPO positive and 88% of TG positive recipients, whereas TG antibody levels decreased in more than 1/2. So not, I think, an impressive story of either induction of thyroid dysfunction or of thyroid autoimmunity following vaccination. And these authors concluded, in fact, that vaccination with an inactivated SARS-CoV-2 vaccine had no severe impact on thyroid function or thyroid autoantibodies, and expressed the view that these vaccines were safe from a thyroid perspective. And that's been the case as well with US larger trials of COVID vaccination. Well, what explains these case reports and associations? I think it's important to remember that although the incidence of subacute thyroiditis is not precisely defined, it is reported in women to be 19 per 100,000 population in adult women. And there are about 200 million such women in the United States who are over 21 years old. So we'd expect about 37,000 cases of subacute thyroiditis during a typical year. In 2021, as I showed you in my first slide, a lot of women received the COVID-19 vaccine. 75% of US adult women, more women than men, I think you've probably heard, received at least one dose of the COVID vaccine in 2021. So about 28,000 vaccinated women had subacute thyroiditis based on its traditional incidence across the United States. And if one looks at the incidence of COVID-19 vaccination over the course of the year, I estimate that about 20,000 women would, by chance, have had subacute thyroiditis within 2 months of their previous COVID-19 vaccination. And I think similar arguments can be made for recurrent or new onset of Graves' disease. Well, the final issue I wanted to talk about is thyroid disease and vulnerability to COVID-19 infection or more severe COVID-19. And there have been a couple of relatively nice studies addressing this issue. And in this study, defining the susceptibility, morbidity, and mortality of COVID-19 infection in individuals with and without thyroid disease, they looked at a medical claims database, including 8,000 COVID-19 infected patients and 32,000 controls, investigating whether they had histories of hyper or hypothyroidism, Graves' disease, autoimmune thyroiditis, or other forms of thyroiditis. And they found in this survey that histories of thyroid disease were not related to increased risks of COVID-19 related morbidity or mortality. So a reassuring study with regard to the vulnerability of thyroid patients to COVID-19 infection. And these findings corroborate a European case control study in patients with hypo or hyperthyroidism who were found not to have an increased risk of COVID-19 infection, and also of a retrospective US study in which hypothyroid patients did not prove to have higher risks of COVID-19 related hospitalization, mechanical ventilation, or mortality related to COVID-19. This was a study looking at thyroid cancer patients, and I bet some of you, like me, have had your thyroid cancer patients ask about their susceptibility to COVID-19 infection or complications. This was a retrospective study at 2 Los Angeles medical centers looking at a relatively small group of 21 patients with treated differentiated thyroid cancer COVID-19 infection, almost 40% of whom were hospitalized and 10% dying of COVID infection. So the thyroid cancer initial disease burden and extent in these patients, the surgical and radioiodine treatments they received, and their current responses to thyroid cancer therapy were found in this, again, relatively small series, not to be associated with measures of COVID-19 severity, ICU admission, mechanical ventilation. Older age and comorbidities other than thyroid cancer were, as we all know, significantly associated with COVID-19 hospitalization. And so COVID-19 attributed hospitalization and mortality in differentiated thyroid cancer patients was actually lower than that previously reported in cancer patients in general, although it was similar to patients with non-thyroidal malignancy at these particular centers. So I've concluded from this imperfect literature that we have in 2022 that there's good evidence for a potential pathophysiology of COVID-19 infection of thyrocytes. I think that side of the story is clear. That thyroid function test changes occurring in some COVID-19 infected patients are really quite typical of those with other non-thyroidal illnesses, and that the severity of non-thyroidal illness, whether it's the degree of TSH lowering or the additional association with TSH lowering, is correlated with the clinical severity of COVID-19 infection, as we've previously known it to be associated with the severity of many other infectious and neoplastic illnesses. It may, in fact, predict mortality, but so far this information has not been shown to provide incremental prognostic accuracy in patient management. I think, and maybe I'm overly enthusiastic about this, but I think that a subacute thyroiditis-like condition probably can occur as a component of COVID-19 infection based on this literature, and that the syndrome might be a little bit different than typical SAT in having lesser thyroid pain and tenderness. Graves' disease relapses may occur. I think there's a less impressive story for this, but it may occur as an epiphenomenon related to COVID-19 infection. COVID-19 vaccine, though, I think is not convincingly associated with the incidence of new thyroid disorders. And I don't think that risk of thyroid disease should be considered a contraindication to immunization. And finally, it's good news that our many patients with thyroid disorders, both benign and malignant, don't appear to be more susceptible to COVID-19 infection, or if they do become infected, to a more severe course of illness or one that will threaten their lives. Now, in closing, I just want to mention that there are similar literatures with regard to other endocrine glands and other endocrine disorders. ACE2 receptors are also expressed in the pancreas, in the hypothalamus and pituitary adrenals and the gonads. COVID-19 infection has been associated with hypopituitarism, with adrenal necrosis and hemorrhage, as occurs, of course, with systemic bacterial sepsis. It's been associated with the new onset of beta cell dysfunction, gonadal dysfunction, including impairment of spermatogenesis. And there is, a postulated story or two or three about how this might occur. through direct entry, as I've shown you, occurs in thyrocytes as a result of endocrine cell dysfunction due to systemic inflammation, analogous to non-thyroidal illness, changes in thyroid function tests. And then perhaps as well, immune antibody mediated hormonal dysfunction, although a postulate not yet proved. So thank you for inviting me back to Cleveland and the Cleveland Clinic. It's really been nice to be here, to be anywhere. It is a pleasure, and I'd be glad to answer any questions. Vinny.
Thank you so much, Dr. Ladinson, for that perfect talk on what might be a developing story at this point. We have Dr. Polanco Santos on the line. Dr. Santos, please unmute yourself.
Yes, thank you for this amazing talk. I wanted to relay one of my patients. She's a young female. She was 6 to 8 months postpartum, and she presented with palpitations, anxiety, and then rapid weight loss after her delivery. And then she had thyrotoxicosis and positive traps. That was around 2 to 3 weeks after her first Moderna vaccine. So what I told her, because she was very hesitant to get the second vaccine, was that probably she had the genetic predisposition for Graves, and then maybe the inflammatory response from the vaccine kind of detonated the disease. So would you agree with that?
Of course, in a patient like the one you're describing, 6 months after delivery, one would also be thinking about a topic I didn't really address this morning, which is postpartum thyroiditis. There's really a lack of case reports that I found relating postpartum thyroiditis to COVID-19 infections. I don't know whether your patient's course or radioiodine or TSH receptor antibody testing suggested her thyrotoxicosis was due to postpartum thyroiditis or Graves' disease.
So the traps were measured around 8 months postpartum. And she's currently on methimazole. She has been on methimazole for 8 months approximately. So that makes me, and I have remeasured the traps and they're still positive. So that makes me think that it's more Graves rather than postpartum.
Yeah, I would certainly agree. The duration, I take it that when methimizole's been lowered or stopped, hyperthyroidism has come back. So I think your patient, is among the tens of thousands of patients who will have the new onset of Graves' disease this year, and whether her previous COVID infection is related or not, I think is doubtful.
Thank you.
I have a related question.
Yes, thank you.
Did your patient ask whether they should get a booster or not, and what did you tell them?
She, that's a good question, and as you know, the Johnson & Johnson vaccine was a single vaccine, but this autumn she would have been eligible, and I don't know whether she chose to or not.
I think all the data you've shown so far, I don't think the risks are any different from other autoimmune diseases that can happen or that can recur or something after the vaccination. So I think at this point, any of my patients will come to me and just tell them, your risks are no different whether they have previous thyroid dysfunction or they have an autoimmune thyroid disease, whether it's Hashimoto's. And we all got those wonderful my chart messages saying, can you write me an exemption letter for vaccination because I have thyroid cancer or I have hypothyroidism. Any other questions from the audience? I don't think we have any raised hands directly in the.
Alan, did you have your finger up there?
I always have my finger up. because I mean, one of the things you bring up was really interesting, both in the case report and in your subsequent talk, is and you mentioned in your conclusion slide, you know, as part of this an initial pituitary or hypothalamic dysfunction that we're seeing in these patients versus a primary thyroid. And I wonder if people, you know, you showed the nice mechanism of how the thyroid cells can get infected. Do we know anything about pituitary or hypothalamic infection by the virus?
Well, of course, the suppression of TSH that I showed occurred in these hospitalized COVID-19 patients in the majority of studies are, I would say, typical of what we see when patients are admitted with pneumococcal pneumonia or burns or, you know, a surgical catastrophe. And that we believe is related to circulating cytokine inhibition of TRH and TSH release. And, you know, so it's not unreasonable, given what we do know about the very high levels of such cytokines in sick COVID patients, you know, to think that there is some central suppression, probably not only of the thyroid axis, but also at the very least of the gonadal axis. I think the best study that I showed you in that regard was the Chinese study where they compared COVID-19 infected patients to other pneumonia patients and found really quite similar patterns of NTI.
I think the other thing that's kind of reassuring is that there are a bunch of negative studies out there, and I think that will really help our discussion. I mean, we both lived through the era where all kinds of diseases were caused by living near high power lines.
Yeah.
And you could show which cancers have an association with living near a high power line and not, and everything else, and all this excitement. And of course, fortunately, that has all fizzled, I hope. You know, and the question is this a similar phenomenon? And you have a high frequency of an event, COVID, and relatively high frequency of the disease, and everybody wants a correlation. But it's nice that there's increasing evidence that I wasn't aware of before your talk that, you know, hopefully most of this will fizzle.
Yeah, I also thought Michelle's presentation showing how the Asia syndrome has attracted such controversial exposures, you know, whether they are Agent Orange or aluminum, and perhaps ought to heighten our skepticism.
I hope Asia syndrome doesn't become the next adrenal fatigue.
Yeah.
That was a very
No, thank you so much for that informative talk. You know, I'm more familiar with the metabolic literature, and it's very interesting. I wonder if in some of these series, if they looked at the prevalence of metabolic disease, because the presence of obesity, prediabetes, metabolic syndrome certainly exacerbates the severity of this illness. And I wonder how much of that might be a component. It's not been mentioned in the thyroid literature, but I will tell you in the diabetes literature, there's a really nice paper in Cell Metabolism that showed that the virus actually reduces adiponectin, it feeds insulin resistance. That might be a positive factor for the new onset of type 2 diabetes, perhaps even, triggering this immune response that's related to type 1 diabetes. So perhaps could you comment on, what you think might the role of metabolic profile and the factors related to insulin resistance in this type of manifestation?
Well, you may know that practically the only comment I made about metabolic diseases was that in one study not showing that COVID-19 infection severity was related to thyroid dysfunction, confirmed what's of course been shown everywhere, which is that diabetes and obesity did. One rather suspects that although it's a severe treatment, that COVID-19 probably improves your body weight and insulin sensitivity, doesn't it? But not the way to go.
I just wanted to share a case, which I think maybe related to the Asian syndrome. I saw a young lady who had breast implants, and she kept complaining about fatigue, weakness, just mild symptoms. And she was insisting that it was because of her breast implants. And when she took out her implant, she actually felt so much better. So possible correlation. And I had another case. She got the COVID vaccine. Prior, she was seeing people hair loss, and it was just a patchy area. After the vaccine, diffuse hair loss, her whole body, she lost all her hair. Coincidence? I mean, there could be. Interesting cases.
Thank you. We are at 8:30. Thank you very much, Dr. Ladinson.
Thank you.
Thank you, Dr. Hong, Dr. Alhaj, and Dr. Lanu for those interesting presentations. Hopefully, after seeing all this literature, we can tell our patients you need to get vaccinated and boosted, regardless of your thyroid status.
Thank you.
Thank you, everyone, for joining us. Have a wonderful rest of your day.
Thank you again.